welcome to part 3 of module 6. In this section, we're going to discuss the role of documentation and some of the day-to-day things that you might do as a clinician that will impact revenue. We'll start by talking about the role of provider documentation and provider queries, something you're probably pretty familiar with. And we'll start, though, by looking at a video from Dr. Glaucom Flecken, one of the nation's top experts, both in medicine. He's an ophthalmologist, but also billing.
Ophthalmology, thank you, both of you, for coming. No problem. We need to discuss your clinical documentation, specifically your preoperative HMPs. Oh, that's the note you sign prior to every surgery that discusses the patient's health status? Yeah, that's it. Okay, sure. What's up? Your last 1,248 HMPs have been identical. That's 3 years worth of cataract surgeries. Oh, is this a problem? Those notes have to be individualized to the patient. How can every patient be an ASA level 2? Do you even know what the ASA classification is? It assesses a patient's anesthesia risk. Different patients have different risk. You need to document accurately. But nobody's going to read my pre-op H&P. Anesthesia uses those notes to help them perform their job safely. Nah. Anesthesia, do you read ophthalmology's notes? Ophthalmology writes notes? Just have Jonathan do it for you. Jonathan is incredibly busy with other tasks. Really, because it looks like he's cutting the crust off your sandwich right now. Fine. I'll write better notes if you tell me the real reason we have to write pre-op H&Ps. They're important for patient care. Fine. Billing. I'm sorry, what was that? Billing, okay? In order to achieve reimbursement, insurance companies require increasingly superfluous documentation, and instead of pushing back against that, we pass the burden on to physicians while gaslighting them into thinking it's good for patient care, when in reality, we only want the hospital to make as much money as possible at the expense of physician well-being. Thank you. Now, will you please write accurate H&Ps? We'll consider it.
All right, so take that for what it's worth. I think it's there's definitely some truth to what he has to say. Check out his other videos; very entertaining. I think whether or not we agree with something or we think something is optimal, whether we want to work within that system or we want to try and improve that system, we need to first understand it. That's sort of the starting point that I took for building this module. So this is a dashboard. As a data visualization and data science person, I have a tremendous number of problems with this dashboard. Like, for example, why don't these things align right there? Why are these text boxes wrapping instead of all in one line? They could have just abbreviated them. That I'll set aside my neuroses for a minute here. What's all this blank space doing? I didn't make this dashboard. This dashboard is bad from just a data visualization perspective. But somebody in your organization very well may be looking at something like this, okay? And so this comes from AHIMA. AHIMA is an organization that focuses on coding and billing health information type tasks. Folks working in that sector. So this is from their toolkit, basically recommending to the individuals working in coding and billing in organizations that they look at this. Okay, so important to sort of understand what different stakeholders are looking at and thinking about. They're basically recommending that organizations look at the query response rate. So when queries are sent to clinicians for additional clarification, that we track the response rate, okay? And so how many of the queries get responses that they're able to resolve. This is from an older version of the toolkit, but they've maintained this into newer versions. Honestly, I just pulled the old one because of how ugly it is, and I just kind of want to make fun of them. All right, so what does this process look like? So it starts with your clinical care, right? And you're going to do that documentation of your encounter with the patient and anything that follows from that. Then it goes into billing and coding, right? And then we go into the reimbursement process. So that billing and coding section really covers a whole lot. So what might that look like for, let's say, an inpatient encounter? Okay, it's going to be different but similar for outpatient and ambulatory settings. And again, this is taken from the clinical documentation improvement toolkit provided by AHIMA. Okay, so this is sort of the flow chart. Again, this is what they are recommending to organizations as a starting point for their clinical documentation process. All right, so if we start up at the top, we see, okay, we start this process, so we're going to pull the hospital census, so pull everybody in the hospital at midnight, review the census for any new admissions, and if we have a patient that is a new admission, we're going to initiate this new worksheet to be placed in the health record, going through all the checks to say, okay, is this a new patient? Do we have all the insurance information we need? All that stuff. And if we have a patient that's not a new admission, then we can just go on to the next step. Okay. So the next step is, and they refer these as physician queries. I think this is a legacy term. This flowchart's been around for a while, so just sort of doesn't fully consider the role of advanced practice providers, quite frankly. Again, not my terms. This is the term. These are the terms that they're using in their their resources. All right, so we need to ask if we need a query. So why would we generate a query to the provider? So this is the full list. I'm not going to read all these, but some of the so some of the big ones, and you may have seen these. So supporting documentation of medical diagnoses or conditions. And this is a big phrase here that's doing a lot of work, that are clinically evident, okay, but without corresponding diagnoses or conditions. So that might be something that's in the notes or is very obvious, but there's not a specific diagnosis mentioned, things like that. The CDI team, the document reviewers, they should not be practicing medicine, right? They shouldn't be putting words, in the mouth of the provider, and we'll hit on that in a few more slides. So resolving conflicting diagnostic or procedural documentation. You have two people who document something at different stages, and they sort of have some kind of conflict between the diagnosis. Okay, so we need to resolve this. How does the hospital bill it? Because if one provider is saying one thing, one provider is saying another thing, we've got to align, right? Clarifying the reason, seeking clarification. There's a diagnosis, but there's nothing in the notes or medical record that seems to support that. Confirming a diagnosis by an independent licensed practitioner who does not meet the definition of a provider. So, pathology says something, or maybe there's something in somebody else's notes, and we need the actual provider to that diagnosis. Supporting appropriate present on admission indicators. This could be really important. So as hospitals are more concerned with quality measures and reimbursement is increasingly tied to those, it's important to document, hey, the patient had this when they came in. And so then if they get readmitted shortly after, it's not really fair to hold that against the hospital. It wasn't something that, that we did, right? So let's think about somebody who has some kind of infection or a respiratory condition, and then they come in for something unrelated, for maybe a surgery or something, and then they're discharged, and then 2 days later they come back and they're admitted for, the infection, right? Well, was that a hospital-acquired infection? Well, no. We need to make sure that we document that when they first showed up. Like, hey, this person showed up and they were sick already, but they still needed this unrelated procedure. So making sure that we have those things in the record. So yeah, just clarifying if things are there or not. Again, long list. This is again from AHIMA. Okay, so we determine, by we I mean our clinical documentation integrity folks are reviewing things, and they determine, hey, there's a conflict or something going on. We need to submit a query. Okay, so if we need to submit a query, then that query is going to get submitted to the provider. I don't know that you may often get verbal queries anymore. It still can be done, but it's definitely not preferred and needs to be backed up with a lot of stuff. I would assume that most organizations today are not doing this, but you never know. Maybe smaller practices still do verbal queries and follow that up. I would assume most of your organizations are doing electronic queries these days. All right, and so one of the key insights with this whole thing is that a query should not direct or lead the provider to document a specific response, e.g. highlighting, bolding, underlining, italics, using yes/no format to obtain a new diagnosis. It is non-compliant to continue sending the same query to the same or multiple providers until a desired response is received. Okay, so this is something that, if you're in some kind of a leadership or management role, can be really important. Making sure that your team is being compliant, because as we'll talk about, the consequences for not doing that can be severe. And the flip side, it's important to recognize if you receive a non-compliant query and push back on that and say, hey, you know what, I'm not going to respond to this because this is not a compliant query. I'd be happy to respond when the format is fixed. So organizations should be using some kind of templates. So AHIMA has promulgated a number of templates. They have a whole long list, both like general ones as well as for specific things. So pneumonia, clarifying types of pneumonia, clarifying types of sepsis. All sort of a lot of the standard things that people run into. They've generated a standard template. Like, hey, here's how you ask for clarification about, you mentioned pneumonia. Well, is it aspiration pneumonia, that kind of thing. Recommend using those templates. A lot of organizations have then, taken those industry-wide AHIMA templates and reviewed them themselves and further customized them. We'll look at an example here in a second. So the three main types are open-ended, basically saying like, hey, there's something missing. Can you go in and provide some clarification about this? Multiple choice. Hey, is it A, B, or C, or other? So thinking back on that key insight where CDI should not be pushing you towards a diagnosis, by saying, hey, it looks like it might be one of these 5 things. Can you let us know which one of these it is, or is it something else completely different? They're not pushing you towards one or another. They're saying like, hey, let's speed everybody's time up. Seems like it might be one of these. Oh yeah, it's option 3. Cool, great. Everybody moves on. Or if not, you're able to say, actually, you know what? It's something else completely different upon reviewing it. The last type is a yes/no. And we'll talk about this one specifically because I think it really highlights how easy it is to sort of veer beyond like, well, I'm using a template. Like, yeah, but you need to ask these questions the right way. So let's look at a compliant example of a yes/no query. So the ED provider documents pneumonia in H&P, and then radiology reports right lower lobe consolidation, likely aspiration pneumonia. Now this isn't a 100% diagnosis, right? Radiology hasn't examined the patient. They don't necessarily have the full picture. they've looked at the imaging, and they've written their report. So then you might get this query. Your ED note documents pneumonia. The chest X-ray report dated 9/5 indicates right lower lobe consolidation, likely aspiration pneumonia. Based on your clinical judgment, can you clarify whether the pneumonia is aspiration pneumonia, yes or no? Okay, so this is compliant. This would be considered compliant because, one, pneumonia is already documented in the record. Now, if you'd not mentioned pneumonia at all, and it was just sort of a general like sick person H&P note, we don't really know. We're gonna sort of do a bunch of stuff, see what comes up. And then radiology says, there's some consolidation, likely aspiration pneumonia. This probably would not be appropriate for yes, no, right? Because you haven't brought up pneumonia, you didn't mention pneumonia, that could be an issue. Okay, so there's a relevant clinical indicator, so the radiology report. If radiology doesn't mention aspiration pneumonia, CDI maybe shouldn't be bringing it up in a yes, no query. Maybe they could do a multiple choice. Like you mentioned pneumonia, radiology mentions this, could you clarify one of these? Or maybe it'd be better for open-ended, like, you mentioned, you mentioned this, radiology mentions this. Can you sort of pull the pieces together and be a little more specific? Finally, the query asks for clarification, not introducing a new diagnosis. Okay, so if nobody had mentioned pneumonia, it would not be appropriate for CDI to say like, oh, hey, like this person has some shortness of breath, a fever, radiology is seeing right lower lobe consolidation. Sounds like aspiration pneumonia. No, if nobody's mentioned pneumonia, CDI should not be pulling that word in. Okay. Some examples, I guess kind of hit this already. So if the ED note just documents shortness of breath, productive cough, all right, and then radiology says, hey, here you go. As the provider, you haven't said there's diagnosis of pneumonia. This would not be a compliant query, okay? Because you're kind of pushing the provider. Provider didn't mention pneumonia, and now I'm putting that word in front of them. That's probably not appropriate because it's sort of putting words in their mouth, leading them to the diagnosis. So the open-ended query would probably be most appropriate there if you haven't mentioned a specific diagnosis. Like, hey, radiology can clarify the clinical significance of the x-ray findings. So radiology said some stuff. Can you pull all those pieces together? And we'll go from there. So here's a real-world example from HCA, one of the largest healthcare systems in the country. So this is from their regulatory compliance team. So they're sort of looking at all of the policies. This is the most recent version from 2024, the last time they updated this. So this is HCA, again, a huge hospital system, their policy for yes-no queries. So they say the yes-no query can only be utilized on HCA query forms that have printed yes-no query responses. So you can't decide when to use yes-no queries as a clinical documentation integrity person, okay? So if you pull, okay, there's a, this specific this specific query has yes-no format for me, cool, I can use it. But I can't just, if it's a very open-ended question or we don't have a template for it, I can't say, you know what, I think I'm going to do this one as a yes-no. Like, no, okay, they really want to be very, very specific on when they're letting their folks use yes-no so that they stay compliant. And the circumstances when they can use it are substantiating or further specifying a diagnosis already present. So that's what we just saw. Hey, there was pneumonia. There was a mention of aspiration pneumonia from radiology. Let's specify, further specify that diagnosis. Establishing cause and effect, did something cause something else? If it's, a fairly obvious relationship, like, hey, we left some 4x4s in the patient and then we closed them up and then something happened as a result of that, hey, did this cause this? We have documentation that these two things happened. They are well documented. You're not introducing a new part of the story. You're just saying, hey, did this lead to this? And then finally, resolving conflicting documentation. So you have two people sort of saying different things. You can ask with yes, no, a yes, no query. Okay, So let's assume that your organization goes through this compliant query process. You submit that query. What happens next? So the query is answered, all right, the flowchart obviously continues. If we didn't need to do a query, everything was done. And then the billing and coding proceeds as it would normally. We assign the DRG, we document the final DRG on the CDI worksheet, and then we move on to billing. So notably, if we are not able to have all the documentation that we need, we're not going to be able to bill this stuff, okay? And so let's see what that might look like. So what happens if the provider does not answer the query? So those charts will be designated as incomplete charts. There should be a process to like try and follow up, you're probably gonna get a bunch of messages, but we know that like life happens, the longer this goes, the less likely it is that it's going to be answered, right? And we'll talk in some of I think one of our other lectures about, the burden on providers of, documentation and all those things. This is hopefully something AI can help with. We'll talk about in a minute. But yeah, obviously it's a big burden, but sometimes it's not going to get answered, right? And so they're going to try and do some other third review. Maybe there's some other documentation that we could find to substantiate everything we need to do the billing. But if not, then we're going to have to just go with what we've got. And that probably means that we're not going to be able to submit the billing that we need, or the full billing for the full reimbursement that we could otherwise. All right. So not all charts are going to generate a query, thankfully. But when there is a query, the impact is often substantial. All right, so now we're going to talk about one way that AI is affecting clinical practice. And this is from a study that was published in 2025, looking at the impact of an AI workflow tool, which was used to draft an assessment and plan. This was conducted at Montefiore Hospital in New York City. They mentioned that the hospital has 726 beds. It's a very specific number, and that's the only hospital that I could find that had 726 beds. They mentioned that it's an academic medical center in the East Coast of the United States. So, I feel pretty good in that assessment. The tool used natural language processing and rule-based algorithms. So rule-based is a lot of like if-then statements. So like if you see this in the EMR, then maybe this should be mentioned. If you see this and this and this, then maybe this should be mentioned. Things like that. Natural language processing, obviously has been around for a long time, well before ChatGPT. Sort of understands language somewhat. I use the term understands loosely, but I'm pretty sure that this study predates ChatGPT. It was published in June of 2025, but the study was conducted from, it ended in June of 2023. So it goes back to like September of 2024 or 2022. ChatGPT came out in November 2022. So if they had done this study with ChatGPT, that would have been really fast. They would have only had a month or two after the launch of ChatGPT to build the tool, get IRB approval, launch it, all that stuff. I don't think that happened. So I think this tool predated ChatGPT. And some of our more modern tools like there's Freed and these other embedded tools in the EHR, which are very common. Okay, so basically suggested some things that should be in the notes. And what they found was that the CDI query rate decreased substantially. So showing a 1.4 percentage point decrease. So in other words, a provider who was getting CDI queries on like 8% of their charts suddenly that drops down to 6.6 on average, 6.6% of their charts on average. So 1.4 percentage points doesn't sound substantial, but it's actually a 15% relative reduction. So 15% reduction in the number of queries you're getting annually. That's pretty substantial. So pretty positive impact. And most of the providers, this estimate also is conservative because providers didn't have to use the tool. They had to attend a training session. So they had to attend the training on it, but nobody forced them to use the tool after that. I think had everybody use the tool, or if the tool like automatically popped up, you'd probably see an even greater decrease in the number of CDI queries. I think a pretty solid impact on provider well-being, and ultimately hospital revenue without increasing workload. Notably, this decreases the paperwork that's required of providers. So, AI reducing the amount of paperwork you have to do. That's, I think, a pretty positive impact. And so what does this translate to in terms of like real world? For a typical hospitalist, this study was focused on hospitalists, and they were all physicians, but I think the effect for PAs would probably be pretty similar. We're talking about between 9 and 12 hours annually. I mean, that's a whole shift. Like, that's substantial of paperwork. And again, this is probably having to take place in your off hours, right? And if you're salary, you're probably not getting paid any extra for this work. And it's not contributing to your productivity measures, your WRVUs. You might be having to do this, the pajama time. Nobody wants to be doing this. So I think this is a pretty solid impact for the good of providers. Okay, so we've talked about revenue that comes from patient care. And a lot of times that's kind of what we think about as, we provide this service essentially, and we get paid for it. And for most businesses, that's like the majority of the business, right? They provide a good or service, they get paid for it, and they move on. In healthcare, again, like the economics are all screwed up. And so many healthcare systems have additional revenue sources that are really critical to their operations. And it's important to understand what those are, where they come from, and some of the types of things that your organization may be dealing with. And again, once you move into leadership or management in an organization, understanding these becomes really critical. So what are some of these revenue sources? Again, they're going to vary by organization, geography, therapeutic area, all these things, right? Pharmacy and other services, huge. So the hospital pharmacy and potentially like a specialty pharmacy. Some hospitals, when I worked in the pharmaceutical industry, I saw a number of hospitals that sort of had set up oncology pharmacies just to manage all that stuff. And then they realized, like, we can push a lot of other stuff through here. And so they, use this existing oncology pharmacy that they'd set up and tried to push patients for example, from transplant to go over to the cancer center to pick up their meds because they wanted to, run all those meds through there because it generated a lot of revenue. Being designated as disproportionate share hospital. This is going to add on percentage to your Medicare patients. So HCMC, for example, I think most of the hospitals in the Twin Cities have this designation. Basically acknowledging that, thinking back to, we get a lot more revenue from the third-party private payers than we do from Medicare. If your hospital has a greater percentage of Medicare patients, than other hospitals, that's going to make it difficult to, break even. Graduate medical education. So this is basically, do you have residents? You have all these residents. They, are going to decrease the productivity of the attending physicians if the attending physicians are doing the training that they're supposed to be doing. so there's going to be some additional payments for those residents. 340B drugs, we'll talk about that in some detail, and there's many others. So again, understand, where is your hospital making its money, and figuring out, okay, how do I exist within this system? So let's talk about the 340B process in particular. So here we have just sort of your standard hospital pharmacy drug dispensing process. So let's assume that the hospital tries to have everybody, if they can, get the meds from the hospital pharmacy, because then the hospital makes money on that. If the hospital sends everybody down the road to Walgreens, the hospital doesn't get anything from that, right? So, sort of the standard process, the pharma manufacturer, there's going to be a middle entity, probably, almost certainly, in between the pharma manufacturer and the hospital. So like McKesson, AmerisourceBergen, or Cardinal usually, but not always. Sometimes hospitals do buy direct, and pharma companies are willing to sell to large hospitals directly and give them a better price. But, be that as it may. Okay, so the eligible provider, in this case the hospital, buys drugs from the drug company to stock in their pharmacy. Notably, this is for outpatient use, so not inpatient, because that would be generally reimbursed under the DRG, right, for whatever that condition was, or while that patient was an inpatient. Okay, and then the payer is going to pay the hospital for those drugs. Okay, so and there could be a pharmacy benefit manager in there, a PBM, whatever the case is going to be for that particular patient, or maybe the patient is just paying cash. However it's going to work. All right, so we'll have the average manufacturer price. Figuring out what a drug costs in the US is a wild process. But let's assume that the hospital is paying this AMP, average manufacturer price, okay? And then they're going to get reimbursed that amount plus a small fee for dispensing the drug. So their margin on, in this case, I think I pulled, I think I used Invarsus XR, which is an extended release tacrolimus formulation used for kidney transplant patients. It's a drug I'm familiar with, okay? So the hospital makes $10 on that prescription. Everybody's happy. Like, okay, I mean, tacrolimus isn't particularly difficult to deal with, once it's packaged. Patients need it every month. You go, you pick it up, $10. Cool. Okay. But let's assume that this hospital is designated as a 340B hospital. So they're one of these disproportionate share hospitals, and they say, hey, we participate in the 340B drug program. What does that mean? So the scenario changes a little bit. Instead of paying the average manufacturer price, the hospital is going to get a rebate of usually about 40 to 60% for specialty drugs. There's a formula that calculates the maximum price they are allowed to pay under that scenario, and typically it's going to be ballpark like half of the average manufacturer price. Okay, so this hospital is only going to pay $500 for this drug, and there's some incentives for the pharma company to participate in this. All these other things. They kind of have to participate if they want to, have any Medicare patients, et cetera, et cetera. So they sell the drug to the hospital at $500 instead of $1,150. The hospital, though, still gets the full reimbursement. They still get the $1,160 that they would get regardless of whatever they bought the drug for, okay? Including that dispensing fee, that $10 dispensing fee. And so now their margin is $660. So you can see it's a huge difference in the margin that the hospital makes on drugs when they participate in the 340B program. They're eligible to participate in the 340B program. Okay, so there's a whole bunch of things from the industry side. You're basically required to give the government your best price, and with Medicare being such a huge percentage of patients, and the military system and the VA and all these huge systems with so many patients, pharma manufacturers are very defensive over what their best price is. Okay, so they won't just lower their price, because if they lower their price, let's say to like get one hospital on board. Hey, I really want to get Sloan Kettering, okay, on board. I really want to get Mayo Clinic. I'm going to give them a really good deal so that I can tell everybody Mayo Clinic is using my drug. Well, if I give that price to anybody, then I have to give it to all these government customers. And then, of course, everybody's going to demand it, right? So pharma companies really can't undercut their price if they wanted to, or without destroying their whole business, right? So this is a way for pharma companies to give better prices to disproportionate share hospitals, and for disproportionate share hospitals to make a lot of money. That sort of sounds really rosy. Personally, I think this program is a train wreck because it distorts the economics of the market, really messes up incentives, and it's basically a way to acknowledge that, look, we know that as a disproportionate share hospital, you're never going to break even, and we are not going to fix that. But you got to break even somehow. And that's not me just editorializing. So there's there's very clear evidence that that's what's going on. So this is a quote from Congressman Henry Waxman from an interview he gave in 2023 on a podcast reflecting on the 340B program, which was implemented in the 90s with broad bipartisan support. And he was one of the bipartisan sponsors of this legislation. And so what he said is that, safety net providers incur losses for carrying so many uninsured and underinsured patients. So, safety net, disproportionate share hospitals. So we need to make sure that the safety net covers them so they don't go out of business. We can't let these hospitals go out of business. We got to do something. So instead of increasing reimbursement, they create the 340B program. It lets them get a discount on the drugs, okay? And it gives the pharma manufacturers a loophole to give them a discount on the drugs without undercutting their best price, because they still get to say, hey, my best price is still whatever, and my average manufacturer price is still $1,160. It's not the $660 or $500, whatever, that I'm selling to the disproportionate share hospitals at. It lets them get this discount on the drugs and then have money left over to provide additional services to low-income people. So that was the plan. The plan is, look, we know that you're never going to break even. No, we're not going to increase reimbursement. Instead, we'll create this end run. And so this really messes up the incentives, right? Because now we're not going to fix reimbursement. We're going to try and create this alternate path for you to make some money. It just really messes things up, in my opinion. And, so how much money are we talking here? It's a lot. So this is from the 340B covered entity report released November 2024 for Minnesota, the most recent report. Covers 2023. We don't have the numbers for 2024 yet, but they're probably similar, right? And it's probably getting worse. So if we look at mHealth Fairview, they made $129 million on the 340B program, okay? Hennepin Healthcare, $70 million. Essentia up in Duluth, $53 million. So this is not like a little, okay, here's a little bit of chump change. This is the difference between breaking even and not for many, many disproportionate share hospitals. And so that's why they're, trying to, in many cases, funnel money funnel prescriptions through their own pharmacy services so that they are able to capture that revenue. And here's the statement from Hennepin Healthcare, the 2024 statement, again, most recent one released. The statement was released in May of 2025, so just a couple months ago, and notes that they receive subsidies for the high volume of Medicaid patients. They participate in a 340B program, which allows them to purchase medications at a discount from from drug manufacturers. Okay, so what's the key insight? What's the takeaway for you as the provider? The key is to understand where your practice's revenue comes from. You can't be a leader, you can't be a manager. It's going to be hard to participate in those conversations unless you know where your practices and organization's revenue comes from. So just put the time in, figure out where's the money come from, so that you can participate in those conversations.